Thank you so much for joining us. We're excited to learn from your model.
Yeah, absolutely. So I think I know a lot of the people on the call, but Lisa Romero with Kaiser. I'm one of the senior community health specialists here in our community health department, and I support our safety net and our access to care grants and donations and community health initiatives. I'm joined, everybody knows Chris Felenz on the call, I think, and I'm also joined by Tracy Copeland and Michelle Lackore. Michelle, do you want to go next?
Good morning, everyone. Michelle Lackore with Kaiser Permanente. I am project coordinator, and I oversee our eConsult program. So Tracy, who's also on the call, held this role for many years, and I've taken the program over from her in the last 9 to 10 months.
Okay, thanks. Chris, do you want to just say hi?
Sure. I'm Chris Felenz. I'm a family doc at Kaiser, and I'm part of the safety net team. I'm the medical director for safety net programs.
Perfect. Tracy, do you want to introduce yourself as well? Even though I think most people know you also.
Hi, I'm Tracy Copeland. I am the project manager for Medicaid and charitable programs for Medicaid for Kaiser. And as Michelle said, I was the project coordinator for the program for about almost 10 years.
Perfect. Well, as Mandy shared, we're here to talk today a little bit about our specialty care eConsult program that we've been supporting for the past 10 years. So again, welcome. We've kind of explained why we're here today, but we're excited to share more. And I always like to start by just sharing my personal experience with this eConsult program because it's really important to me. I am a PA by training, as some of you know, and I started my career at the Salud Clinic in Commerce City and was in clinical practice when this eConsult program launched 10 years ago. And I remember the excitement. I remember how great it was to have access to specialty care consults for taking care of our patients. And so it's been really great for me to kind of go on this journey and get to support the program from this side as well. I want to just sort of reintroduce our Kaiser Permanente team that supports this program. You heard from Michelle, myself, and Chris today. We also have Dr. John Riapel, who is our specialty care liaison and a GI doc here with CPMG. And then Dr. Jay Roosh, who some of you will remember, who was the medical director for Safety Nets previously. He's a cardiologist with CPMG, and they are both really strong proponents of this program as well and support internally and contribute to the consults as they come in. So this is the Kaiser team.
Can you define CPMG?
Oh, yes. I'm sorry. That's Colorado Permanente Medical Group. So they're the physician group here at Kaiser. Thanks, Mandy. Okay, so a bit about the program background. Why did we start this program 10 years ago? So we are lucky. We have Chris and Tracy who were there on the Kaiser side when this got started, and they're a great source of knowledge. But as a general goal, the program was really intended to extend access to specialty care for patients who would otherwise go without those services. Our goal was, again, to support primary care providers at our safety net clinics, help with some of that advice and clinical recommendations, even when in-person care was not available. And sometimes for in-person care when we did have the capacity to bring folks in, really with the aim of providing advice that would help those primary care practitioners really maximize their scope and really get the maximum care for their patients in the safety net setting that they could. And as a lot of you know, Kaiser's mission as a nonprofit healthcare organization really is to overall improve the health and well-being of the communities that we serve. And this falls under the safety net strategies that we support. So this program was funded and came out of our community health or community benefit department. And I just like to highlight that is a big part of our mission and sort of the background of this program as well. So again, we launched back in 2013. We had 8 safety net partners around primarily the Denver metro area, had 200 primary care providers signed on to and enrolled to submit eConsults on behalf of their patients. And on the Kaiser side, we had specialists, 91 of them, contributing across 8 specialty care departments. Over the last 10 years, we have grown a bit. We are bringing on a couple new clinics this year, which is really exciting. And we've grown to 306 primary care providers enrolled in using the program. And we still have our 8 specialty care departments, but we have a few more specialists involved, up to just over 100 on the Kaiser side. Our specialty departments are listed here. We have allergy, dermatology, endocrine, GI, neuro, ophthalmology, pulmonology, and rheumatology. We've also had cardiology involved off and on throughout the history of the program. And the departments highlighted here with an asterisk are the ones that are currently offering in-person visits. As I mentioned, all of these programs contribute to the eConsults, and then for situations where we can provide some care internally that helps the primary care provider and clinic manage chronic conditions, we can bring folks in and perform kind of basic diagnostics or basic treatment to help with that chronic care management. And it's capacity dependent, but again, the departments here with the star are the ones that are currently offering in person. So I'm gonna hand off to Michelle. She's gonna go over some of our program data, and then we'll go from there. Michelle, I can't see you, just let me know next slide.
Okay, thank you. So as Lisa mentioned, just wanted to highlight our program milestones over the years. So over the past 10 years, we've done approximately 4,500 e-consults. And of those, about 2,100 have resulted in face-to-face visits. Some of the departments, such as ophthalmology or dermatology, are often more than one in-person appointment. So that's why we have noted that some, like a little over 1,000 are unique patients. So quite a few of those are the same patients who we are able to, or like we see them more than one time. Next slide, please. And here we just wanted to share what the program looks like across the specialties. So GI has been our most utilized, most popular over the years, but unfortunately, due to our internal access, we're not able to do in face-to-face GI, which means there's also not a lot of e-consult GI that can be done. But thankfully, we still are able to support in all these other departments. We still have a lot in ophthalmology and dermatology. And then also cardiology has historically been a popular or well-utilized. I shouldn't say popular, it's not a popularity contest. They're all awesome. Next slide, please. And then we just wanted to show what it looks like our program total is broken out amongst the safety net clinics that we've worked with. So as you all likely know, Clinica has several locations. So that is why that slice is so big. That's all the Clinica clinics rolled up into one sliver. But we're fortunate to we're grateful to work with all these PCPs across the clinics. Next slide, please. And then next, just want to talk briefly about how our process flow. So we work with the platform, we utilize the platform Net Chemistry. And so that's where the PCPs all receive a username to log into the Net Chemistry. And so they go into Net Chemistry to submit their e-consult. And then Lisa and I manage the e-consults on Kaiser's end. So we go in there, and when we see that there's new e-consults based on the specialty that it comes in for, we have different process. Each department handles it a little bit differently, but we then log into our internal system and message the doctor or department for who needs to respond to that. Or the current e-consults. And so then the specialty doctor will also log into Net Chemistry and respond to the e-consult. And then from there, sometimes there's some back and forth conversation, but once it's been resolved, the consult is closed, and that's when it's either the question is has been answered, so it's resolved, we mark it as closed resolved, or the other thing that happens oftentimes too is if we have the capacity, we then close it and it transitions to a face-to-face appointment. Next slide, please. And so what that looks like for our face-to-face visits, we work with, well, first I'll start with, we are only, although the platform, the eConsult portion, we doctors can answer questions, the eligibility status, or am I saying that? I don't feel like I'm saying that correctly, but their insurance status does not matter for the eConsult. The specialty care doctors will answer questions about anyone. However, for it to bring patients in face-to-face, we are only able to bring them in if they are truly uninsured. So we're not able to support Medicaid patients. And that is because we extend charity medical financial assistance for those patients. So it's truly for those uninsured patients. So that is something we determine first. And then we, Lisa or I, we receive patient demographics from the PCP, work to get the patient in a Kaiser MRN and extend that CMFA. We update that in our records. And then depending on which specialty department it is, scheduling works a little different for each department, but basically I work in the net chemistry platform to communicate all the steps along the way so that the PCP is in the loop with what's happening on the Kaiser end. And then after appointments happen, I then upload the notes from the appointment into the net chemistry platform so that the primary care has all that information. And then we just a couple notes about follow-ups, cancellations, and no-shows. There are times when we just, for rescheduling purposes, we ask the patients to need to call and reschedule the appointment. And after 2 no-shows, we have to close the case or close the face-to-face option just for our capacity's sake. And then some of that's a little bit of internal notes, but just asking that there are oftentimes, like I said, for dermatology or ophthalmology, where the patient will be seen, need to be seen more than once. And so we just ask that the specialty department copies me on our internal system so that I'm aware.
Perfect. And it might just be worth noting again, I know I mentioned this at the beginning, that the idea with the face-to-face visits are to meet needs that are sort of somewhat limited in scope. And what I mean by that is this program really isn't designed or doesn't have the capacity to take on patients for long-term management of some of these conditions. But if there's, the GI example is a great one. And I think that is why it was so highly utilized, is if a patient needed a colonoscopy or endoscopy, we could bring them in. That's care that we can provide within our 4 walls, covered under CMFA, get treatment or diagnosis for the primary care provider, and then transition that care with that additional information back to the safety net clinic. So there's oftentimes questions about patients who need dermatology is an example, where if a patient comes in and we can perform a biopsy within our department, but if it does result in needing additional long-term care for, say, like a malignant melanoma, that's where our program capacity is limited. We can't bring folks in for long-term care. So we get a lot of questions about that. So I just thought I might highlight that before we move on. And of course,
I just want to acknowledge one question in the chat that is about but exactly how would a PCP make a referral to a face-to-face visit? So it's actually first they submit an eConsult, and it's all based on the capacity. And something that I'm realizing now that would have been helpful, we do have for each of our specialty care departments, we have guidelines as far as like what we are able to see for face-to-face, and the PCPs all have that information as well. So they aren't able to refer directly to request a face-to-face appointment, but there is some situations where obviously it would be most helpful if they could be seen face to face, but the purpose of the eConsult is to ask questions to be able to better support the patient. So we don't, please correct me if I'm not speaking correctly, but there is not a way for the PCP to just make a referral for face to face.
Yeah, that's correct. So I think that's an important point. So I'm glad that we saw that in the chat, because you're right. All of our referrals are funneled through the eConsult system, and then if appropriate, brought in for face to face. Excellent. Well, I'll pivot just a little bit and share. Oops, there we go. Kind of some of the things that we feel like have really been successes of the program. You know, we've been proud to be able to meet some of the need for our communities. We've established this eConsult program. Again, we keep highlighting the 10-year mark, a decade of experience, and really got the eConsult program up and running well before, you know, that has become sort of the norm during COVID. So it was really a great learning experience. I'm sure that Tracy and Chris can tell us all about some of the challenges that they kind of worked through. But we've, you know, through this platform, we've been able to meet the needs of over 3,600 patients through eConsults and face-to-face visits, and contributed to the care that over 600 of our safety net primary care providers are providing for their patients. So really excited to share that impact. We've really worked to create a community. You know, we have our triannual meetings for the leaders of the safety nets that participate. The Kaiser Permanente team is there, and then we will bring in other stakeholders as relevant for meetings. We try to create educational opportunities. That certainly fell off a bit with COVID, in my understanding, as many things did. But we, you know, in the past, we've done CME sessions and that sort of thing for our participating clinics. And again, just really connecting to the mission. One thing I think is important to highlight here, you know, we talk a lot about the benefit for our community and the benefit for our safety net providers and clinics, which is, you know, incredibly important. But what we also hear from our specialty departments and participating specialty physicians is that this is really contributing to their joy in work and contributing to their desire to give back to the community. And so I think that sometimes that's a really important piece of this that gets overlooked. And so just really want to highlight that this has been beneficial to multiple parties. Unsolved opportunities. There are certainly things that we've learned and that we continue to try to work through. Primarily, first and foremost, I'd say just our own organizational capacity and access is variable. And, you know, the unfortunate truth of having a one organization system is that when that one organization's capacity changes, the capacity for these services is directly impacted. And that happens with departments coming in and out of the program. And so that will affect even eConsult capabilities, or for our own internal access for in-person visits can impact our ability to offer or not offer the face-to-face option for certain specialties. And GI is a great example of that right now. You know, there's also certainly challenges as it relates to the system of eConsult before face-to-face, right? We know there are situations where sometimes that firsthand physical exam or firsthand, you know, imaging or you know, I'm thinking of like ophthalmology exams. You know, a lot of those docs are happy to review reports and images and information they get from the safety net clinic. And sometimes that can really help them make an eConsult. And sometimes it just doesn't quite take the place of seeing that person in an exam room. So there's always a challenge of how to navigate that. The platform and just logistics of working across multiple clinics with multiple systems is always a challenge. As Michelle mentioned, we use the net chemistry platform for our eConsult submission. And while you can integrate net chemistry with several EMRs, it doesn't integrate with all. And that has significant cost associated with it, as I'm sure you can imagine. And so that becomes a challenge both on the safety net side and sort of figuring out how to make this as efficient as possible. And we know that anytime that we're asking folks who are very busy in their clinical day to leave their EMR and go to another system to submit a consult. It just adds a little bit more time and complication. So kind of relatedly, that can make data tracking a little bit more difficult because we're having to kind of compile and transfer data back and forth from different systems. And then the ever-present challenge of turnover, both on the KP side and on the safety net side. There's that need for continual training. As folks leave roles and join other roles, we lose some of that organizational and historical knowledge. So we just have to sort of be thoughtful. And this is fresh in our mind, of course, because this program has transitioned hands here on the KP side in the last year, kind of how we have a plan for that continual training and knowledge sharing. So want to pause here. We had created some bullet points and things we've thought about for kind of what's next and where we go from here. Things that have been on our mind are kind of how this program can or should or might interface with HCPUF's program. So I'm really glad HCPUF's on the call today. And thinking through some of the challenges, especially with, as I mentioned, having a one organization system really creates a kind of a real on-off switch as it relates to access to departments and consults. So thinking through, how could we dream up a more comprehensive or pooled resource where some of this capacity is shared across other specialty care organizations as well. Many of you are probably familiar with programs like Operation Access or Program Access, where they have sort of that pooled resource, and it makes the system a bit more resilient to when one organization's capacity drops, others can sometimes absorb that. So those are sort of some of the things we had thought about. Definitely want to take questions. I think there were some others in the chat. So what I might do is stop sharing so we can all see each other.
I have a clarifying question to your question, Mandy. How much FTE does it take to support coordinating eConsults? So do you mean as a whole program? Because there's like, do you mean the physicians?
Just the staff power, like you and Lisa are sharing. Once the eConsult comes in, then how much FTE does that take to coordinate?
So I can speak for myself. It's about this is like sounds weird, but it's like 35% of my time is dedicated to the eConsult program. And Lisa, do you know?
Probably 10 or less for me.
Yeah. So, and this is a transition because, and Tracy can speak to what her percent was, but yeah. And then, yeah, so that's about the program management of it is about like 45% of a person, but it also ebbs and flows. And sometimes it's more, sometimes it takes up a lot more time in my day, and other times there's not as much to do on a day-to-day basis, but it's definitely there are like pieces to manage every single day.
Right. Thanks. We've heard in this group, oh, we just need an organization to take something like this on for Aurora. There's so many resources, and it's nice, I guess, to hear that it's about half an FTE.
But it could be more too. It's like, just like with anything, you can make it can, there are like ways you could reach out and do so much more. But it's also, just the capacity.
I'm thinking 0.5 as like the floor for that.
Yeah. I agree with that.
And I would add that it's probably feasible for us to operate at that FTE level because this has been up and running and operational for so long. Mm-hmm. I'm sure Tracy would share that in the early days that she was probably like 2.0 FTE on this program.
Yeah, agree. And I just like great opportunity to give kudos to like the incredible groundwork that was laid from Tracy and also some of our partner physicians. So yes, like definitely streamline the program.
Yeah,
for sure.
Yeah, what I would add is that in its inception, when it first started, we did have a dedicated person from CCHN who actually helped us train and bring on all the new PCPs. And so, yeah, in the beginning, you're going to need more than that 0.45 or 0.5 for sure.
I'll go ahead and interject here if I
Sorry,
may.
Phyllis's hand has been up for a bit. Phyllis and then Rich.
Trying to get her.
Go ahead,
okay.
Phyllis.
I'm trying not to be too, anyway. So some of our clinics have started using, so one of the things people love about the Kaiser program that they're using is the responsiveness of the providers and the interaction that they have with them. The flip side is it's a little frustrating because they do reach a point where just there's nothing else that can be done. So they still have a patient that has high need and nothing can be done. So some of our clinics are testing a new program that's nationwide called the MAVEN project. So that's something else. It has a broader set of specialty care than what Kaiser is able to do. For example, when we were back before COVID, when we were looking at this, urology is a big one for our clinics, and that's not possible for Kaiser. So I think that's one of the things to think about from a futuristic approach. Is there a way to broaden the specialties, and is there a way to expand the capacity of what can be done for patients based on the experience that we have? And then I did have a question about, it looks like it's on average two in-person visits for the total people who come and get face-to-face visits. I think you did a nice job calling out that there's going to be some no-shows. I'm just curious what percentage of the people that are referred for inpatient visits end up being no-shows, because that's always a complaint of specialty care providers is, yeah, we do this, but they never show.
We don't have, it's a great question and something that actually, like you just said, we've heard that recently. And I'm like, but I look at the data, like, no, people do show up, but like maybe they're not coming through your caseload. Or so short answer is I don't have a percentage, but it's something we are curious to have a better understanding of. So how about this? I will get back to you because we also want to have a more firm answer to share with the specialists that say that too, because I'm like, I disagree.
Yeah,
Me too, but
It happens. But I would say if I could just guess, and maybe Tracy would have a better pulse on this, I would say 25% no show.
yeah, see, like that, it's so great that you guys have this longevity to be able to take a look at it. So yay, I'm super excited about that.
yeah.
And sometimes I will say too, this was not your question, but the no show is also, it's like the time it takes for us, which I feel like we have a pretty quick turnaround, but if someone has something like that they want to get resolved, or so in the time it takes us to get the MRN, like a Kaiser MRN, and like get them in the process, sometimes their no show means that actually they've found services elsewhere. And so it's just that like the communication is not always as clear to know that. So we're reaching out to them and they're not, I wouldn't necessarily always call it a no-show. Sometimes it's like unable to schedule an appointment, and that's because they found services elsewhere, which is ultimately fantastic. Like they've received care. So
Yeah, that's fascinating. Thanks.
Rich.
Okay, yeah. And before we end, certainly I'd like to get Lauren and Dana to talk about the HCMA program, but with the Kaiser program, part of our health access and specialty care review was that primary care folks sometimes aren't able to properly prepare their patient for for in-person visit. The primary care fellow or gal feels that it's necessary, but doesn't know how to prepare. So it seems like this Kaiser program would be good for that. For example, GI. It's not going to get a face-to-face with a GI, but at least they can get a consult on to make sure that that patient is prepared to see the specialist that the primary care will refer to. Does that seem accurate?
I think let me just make sure I understand. So if say a patient is being referred to GI out, not Kaiser, but they know they're going to go to GI, are you referring to sort of pre-visit diagnostics, labs, imaging, so that they can show up to that, provide that specialist visit with everything in hand Or patient
Exactly.
instructions, both, okay. Yeah, I mean, I think that would be true. I mean, that's a lot of what we do when we are bringing somebody in. What the specialist will recommend is we need to see them, but get these labs first, or try this treatment first. And then if that doesn't work, you get this lab and then we'll see them. So there's a lot of that kind of pre-visit work that can be done through the safety net, so that that visit with a face-to-face visit with a specialist here is as beneficial as possible, in the sense that they can really, it's not, hey, here, thanks for coming in, go get this lab and come back in 2 weeks. They show up with everything that they possibly can.
Yeah.
And it's also like, not perfect, because then it's like, we're trying to get someone in. This just happened. We like got someone in quickly, which is great. But then they realize like, oh, we don't have all the medical all the like past history from the safety net clinic. So it's not perfect, but it's certainly so great in so many ways.
Great.
But I would say that is like also part of our role of helping like facilitate the eConsult process, is to try our best to like help navigate those as best as we possibly can.
I'm reading in the chat now too. Mandy, you asked about other Kaiser models. So in our other regions, I believe, and Tracy and Chris can speak to this as well, the original vision was to try to have this sort of model in all of our Kaiser regions. And it really worked in Colorado. It didn't work so well in others. I think, is it Washington or one other region has something somewhat comparable, right, Chris and Tracy? But I think ours is the most robust program.
Mm-hmm. There isn't any program just like ours in any of the regions. We did try and make it go across regions, but it was a very big, very expensive proposition. And the other regions, this is unique to Colorado, as I learned. The other regions didn't feel so much of a need for it, in that because they don't have Medicaid fee-for-service, they have capitated Medicaid, the need isn't as bad. And so here we really do have an issue with specialty care for both uninsured and Medicaid. In these other regions, it's only for uninsured. And anyway, the program didn't go off in the other regions. Pacific Northwest has thought about doing something similar, but to my knowledge, they don't have anything in place.
I do want to add something when someone asked about the specialties that are currently included. I know in the beginning, we did kind of do a survey on some of the specialties that people requested. And so I believe urology was one of the specialties that people said that we didn't really need. So we did kind of try and base the program on the need of the community, as well as which departments at Kaiser had capacity to participate in the program. So that's why, neurology answers consults, but they don't see patients because the department wanted to help, but they just are always overwhelmed. There's never enough staff to see all of our KP patients. So, that is one of the reasons. And then I don't think it has been mentioned. It took, Chris, correct me if I'm wrong, didn't it take almost like 5 years to get this program off the ground?
It took several years, yeah. We talked about it for a couple of years. It probably took 2.5 to 3.
Yeah, it took a while to get it off the ground. So, and it was kind of the brainchild of Chris and Dr. Jen Allen Davis and Lynette. So it was a heavy lift. I think I came on as the program was taking off, so I wasn't as active in that beginning process.
Yeah. I mean, the biggest challenge we faced was kind of documenting that there's a need in the community. So we had to do a large statewide survey. And then we had to convince our operational leads and then also see where their availability, their access was. And so that's kind of how we came upon which departments participate. And, we do have ongoing dialogue with the medical directors of all the community health centers that are part of the program, and ask them where their needs are, to kind of see if there's something that we can, a specialty that we can bring on. But in the last couple of years, we've really been hampered because of access issues as far as bringing on new departments, unfortunately. So.
It's interesting that neurology wasn't ranked high then, because we recently partnered with the Department of Family Medicine to do our survey of specialty need in Aurora, and neurology was ranked the highest for a number of reasons. So it depends on the community and the year, and exactly our survey didn't say for eConsult, it was just a more general, what is a specialty care need? So maybe we can look into that for what that would look like. I don't know.
Yeah. That is interesting.
Mandy had asked 3 questions in the chat. Have we answered all of those? Mandy had asked 3 great questions in the chat. I want to make sure we acknowledge them. Did we talk about the model? Yeah, we talked that. How extensive the training? Did you guys talk about that?
We didn't really. It's probably, again, Tracy and Chris chime in. I think it would sort of depend. There's so much training that happens amongst the providers in our safety net partners now when they come on board. Oh, here's the program. Here's how you use the portal. Talk to, Kaiser, they'll get you a login. It's sort of handed down like that in a lot of ways. At the beginning, I'm sure it was quite extensive. And I do believe that net chemistry can offer training. But I think when our program launched, I don't think that was the resource that we used. So I don't know if Chris or Tracy can share kind of how extensive that is initially, if we're thinking sort of onboarding to maintenance phase.
Yeah, and I guess at the root of my question is there hesitancy at the safety net clinics? Like, I don't want to have to do this, more training, or what is the approach there? Are clinics coming to you, or are you kind of selling it to clinics?
I can speak to that. I think it's a lot of word of mouth within the clinics, it seems like, and there's like a care, some of them have care coordinators or someone who's like a little bit more of a point person at the clinic. And so a lot of times they email me as they have new providers who come on. And so then they say, like, we have 2 new providers. Can you please get them usernames? So I would say it's more like we honestly actually don't reach out a ton as far as like to recruit more people. It's more the clinics let us know that there's a new provider. And so then I create a login for them and send them an email with some user guides. And then also developed during Tracy's time, it was a resource that has like screenshots. So it's kind of like a virtual training that they can utilize and access. And then we always say we're always available for questions. So, but honestly, I don't get a ton of questions other than I'm not able to log in or little stuff like that.
Yeah. And I do think, Mandy, sort of the other kind of half of your point about is if I heard correctly, the kind of the workload of making this program happen, is that sort of a barrier for clinics joining the program as a whole? And I do think that there are some clinics, especially, maybe we're just based on how they're operating, it felt like a burden to have the providers have to log into a separate portal and submit this information every time they had a question. So some clinics have found a workaround where they ask their referral coordinator or their care coordinator or somebody else on their staff to submit the referral on their behalf. And they say, here's all the information. Can you log into the portal and send this to this specialty? So that has been an option that we've also kind of walked clinics through, because I think you're right. I don't think that fear has kept anyone from joining the program. I think because the option to have specialty care consults is something that is such a high need, but there is that fear of like, okay, now my day is already so busy. Now I have to get out of the EMR and go to this other system and now get the information back and forth. And so we kind of having a centralized staff person who can help with that really helps with the workflow, especially in the higher volume clinics.
Thanks. I know that I'm not, no one go anywhere if you don't have to, but before anyone starts dropping off for a potential 11 o'clock, I want to thank Kaiser Permanente for the 15 years of effort that has gone into this 10-year anniversary. It's so impressive. And it was kind of like a best kept secret. Like Tracy's been coming here. I had no idea, Tracy. I'm just so excited to help share the success of this, and wanted to point out that even earlier this year, we're like, what about an eConsult program pilot where you go through the eConsult before doing a face, like you all have done it. We're not recreating the wheel, but maybe we can help adapt the wheel and expand it, and maybe potentially more of a statewide approach or a regional approach. Not just a little plug for everyone. Hopefully that picks up steam as well. There are a couple more questions, but I wanted to thank you all so much for your time in participating with the Aurora Health Alliance, with health alliances generally, and for caring about the safety net.
Yeah, I think I can speak for all of us when we say we would love to see this wheel expand and grow and become part of a more comprehensive resource, so that we don't have our eConsult program and this eConsult program and this, that makes the burden on our safety net clinicians greater, not less. If it's like, okay, well, I have this patient who needs to go to this portal and this patient needs to go to that portal and this one goes here. So yes to Mandy's.
and Kaiser is not the only player in the game, right? It might behoove all of us to think about a way to collaborate and spread the load a little more.
Absolutely. Yeah, absolutely.
But thanks. I just really back Mandy on that. Really appreciate this overview. I learned 200% more on Kaiser. And I know that HICPUF is with us also, and they're working on a platform. And I wonder if they could comment on that. But they've heard about new chemistry, Kaiser's interface with new chemistry. Can you talk a little bit about Dana or Lauren about how HICPUF's platform will look?
Or Brittany, I saw you.
Or
you
Brittany?
Come on camera.
Yeah, so I apologize. I didn't have anything prepared to actually present today, but I can just give a really high level kind of overview of our program so far. So we are still in the procurement phase for procuring a vendor. We did make an intent to award, which we announced to Safety Net Connect. We did go and complete the contract. It has been sent to CMS for their review and approval. It was actually sent on Monday. So they have until June 30th. So we can't actually start any work, start any sort of discussions with that vendor until it has been approved, just in case CMS comes back and says, no, we can't, or there's issues with our contract. We have to take it back and work on it some more. So there's not a whole lot I can really kind of dive into at the moment, just because it hasn't been approved yet or executed with that vendor. We are looking at a go live date, however, for our platform on or by 2/1/24. So our hopes are that CMS comes back with no issues with the contract. We are able to then execute it with that vendor in July. So we would be starting DDI, so design, development, and implementation with them late July, maybe August, unless CMS is able to do their review much sooner. But we do have to give them those full 60 calendar days because they can take up to the very last minute with that review.
The bureaucracy.
Yes. So we're hoping, fingers crossed, it doesn't take the full 60 calendar days, but that is what our timeline is built off of right now, just, on that assumption that it will. Otherwise, we have a link to our website. I can drop in the chat here for a little bit more information, but once again, it's a little bit high level. So let me hang on here. Okay. There is a link that we have a little bit more information, but We do plan on starting stakeholder engagement in earnest in the next month or two. We are able to go ahead and start that, but we have to just be very, very careful about what we say and everything before the contract's executed. So we've been kind of trying to wait until closer to that contract execution date. But we do plan on starting it very soon. So
I think the health alliances can help you spread the word for that, so that
Wonderful.
you can have robust and committed engagement with that. Phyllis, you're raising up the mountain with your hand.
Intentionally this time. Brittany, when I look at their website, it is very behavioral health oriented. So I'm curious if there are limitations like the Kaiser Permanente program in terms of the types of specialties that are involved.
I might have to defer that question. I was hoping somebody might be here to help answer that specific question, but I don't, so I'll have to take that one back and get back to you. I apologize.
Yeah, I mean, great that they have behavioral health as part of their thing. That's super awesome given how much we suck at it in the state. But by the same token, like those two worlds don't necessarily always work well together, which would be a red flag for me.
And Brittany and you guys, I know you've brainstormed this and the design is not out, but you've heard Kaiser's platform. Would the HICPUF platform statewide be something like the Kaiser platform?
Sorry, off mute. Yes, so it does sound like there are a lot of similarities with that platform.
I also have another question, and Brittany, and sorry if this is, I know you try and do high level stuff, so totally understand if you don't have the answer as well, but I know integration has always been kind of a big kind of topic area. And so I was wondering from a high level perspective, what are some of the conversations there so that like the Kaiser program could be like, okay, we can start kind of maybe start preparing for like any type of integration so that, as we've mentioned before, we're not duplicating or making more work for other, physicians and clinics.
We are having some conversations about that with the integrations. It is quite the expense. So our budget is very limited to only a few a year. We do have a single sign-on option that will probably be used for majority, just because it was going to be, I think, $10,000 per each instance of trying to sign on for an integration for an EHR. So it's going to be just incredibly costly.
Thank you.
You're welcome.
For mostly, I think this was aimed at Kaiser. Molly had a question regarding the public health emergency ending, which is leading to redeterminations and possible end of eligibility for Medicaid members. Is Kaiser, or just more generally, the eConsult program positioning itself to add new uninsured patients who might lose care through that process?
So
or do.
Maybe the confusion is, so is the question if Kaiser is going to take on the uninsured patients as members through this program, or just
no? Maybe a heads up. Our eConsult, is the eConsult platform ready for maybe an increase in the next 6 months as people figure out insurance?
Yeah.
Molly came off mute, so you can.
There
you
will
can
be
help.
more. You're targeted towards uninsured, which is essential. There will be many more uninsured folks, and it's every month over the course of the next year.
Yeah.
There will be more uninsured people in general because their Medicaid eligibility is redetermined and determined to be no longer appropriate or eligible. So
Right.
the whole state needs to think about how are we going to manage this new unserved population who have been receiving services through Medicaid and will no longer be eligible. So if they're in the middle of treatment or in the middle of whatever, I think any provider needs to be alert to this situation. And I'm not saying Kaiser should do something about all of it, but if you're working with safety nets and safety nets serve uninsured, there will be more people who will. So we should think about it as the grown-ups in charge about how we're going to help with this transition to people not having access to paid care.
Can I second what Molly's saying and ask that again, if we're talking about going forward, what would be helpful? We are not going to have good data about the increased numbers of the uninsured other than anecdotally until the next CHAS survey, EFAS survey comes out, and that's a year away. So
just in terms of anecdotal, Phyllis, I was talking with BB at Doctors Care yesterday. They've already seen a 5% increase in uninsured, and they've got the best network for getting people into eligibility and care.
Right, I understand that, but if the participants in the specialty care program, your participant community health centers, FQs, our safety net clinics, if you can have a conversation with them or identify an increased potential increased caseload, add that to the debate early on, as kind of like a canary in the coal mine about the fact that there is a problem with the uninsured in the state. I mean, I would think that we've had a 9% flat rate even through COVID. With the unwinding of Medicaid, we're gonna see more. There's just no question about that. So, and the whole policy focus in the world is, oh, we're gonna get people coverage. Well, that's fine, but at least being an assister, I can tell you that going from paying nothing for your insurance to now having a $3,000 deductible, even if you have zero on your premium, is not going to work.
Right. Yeah, you're effectively, I mean, if you can't cover your deductible, you effectively don't have coverage. Anyway,
the way the plans work. Yeah.
Right. And I do think that what's interesting about our data, and will be interesting to compare past, present, future, is this program through an eConsult lens has always served Medicaid and uninsured. So we can kind of track the eConsults coming in. The face-to-face visits has always been uninsured, and we have the data that predated COVID and predated the public health emergency by 7 years, right? And so we can sort of, I think, map those trends to see what's happening. And I think to that end, the program capacity, I'm hoping it will be able to handle the shift in payer source or lack thereof, but we'll, certainly keep an eye on the numbers and see what we can learn.
Yeah, well, that's an interesting point, Lisa, is that for the purposes of the eConsult program, actually people losing their Medicaid won't change the volume of the eligible patients that might be referred into our eConsult program, right? Because they currently have Medicaid, they can be referred in via eConsult now. Maybe they'll be uninsured, they can still be referred in. But as far as kind of our face-to-face volume, we might see a blip, not a huge blip just because we offer such limited services through face-to-face, but it could happen for sure now that more people would be eligible for that because they'll be uninsured.
Our next access to specialty care meeting is the beginning of August. I'm pulling up the date. August 3rd at 10 a.m. So everyone have a great summer. Send good vibes to the state's eConsult network getting up and going. And we're always here for discussions and side conversations to move this work forward. Thank you so much for coming.
Thanks, everybody.
Thank you.
If you think of other questions, don't hesitate to email, for those of you that are still hearing me.